Okay, I went through this already. This is an example then of what we would see on histology when we look at a normal term placenta. These big villi with lots of connective tissue are the stem villi, and these smaller villi intervening are the terminal villi, which are the functional unit of the placenta. So the terminal villi are numerous, they're packed with capillaries, and they're covered by a thin layer of trophoblast. They have 4 to 6 capillaries, which are separated from the trophoblastic lining by a very thin basement membrane, and this facilitates efficient gas and nutrient exchange. And like I said, it comprises approximately 40% of the total volume of the placenta. So we'll take sections from this will be the fetal surface. These are the chorionic vessels that we saw earlier, fetal vasculature. These are the stem villi, and then the normal terminal villi, and then this will be the basal plate or the maternal surface. Again, the terminal villi represented. This is just showing a cross section of a normal term villi, and you can see that you've got the vessels opposed to the edge of the villi, which are called vasculosyncytial membranes. You'll see that on your report. It's a feature of a normal terminal villus. Okay, Gamma went through that. So placental pathology is most likely to provide explanatory data in 2 situations. When you have an acute unexpected adverse outcome like birth asphyxia, a depressed 5-minute APGAR score, neonatal encephalopathy, a sick neonate in ICU, or a critically ill mother. Also, it's useful when you have a chronic and unexplained adverse outcome, like fetal growth retardation, discordant twin growth, stillbirths, fetal death, neonatal maternal death, recurrent fetal losses, and spontaneous preterm delivery. Okay, so then we're going to start looking at the 4 main placental diagnoses as classified according to the Amsterdam Placental Workshop Group that was published in 2016. And we're going to use this table, which shows the main adverse outcomes being spontaneous preterm birth, fetal growth restriction, central nervous system injury, stillbirth, and fetal death. And this table, what it does is it lists the adverse outcomes in order of frequency, and also distinguishes those that occur in the early preterm and late preterm or term. So the first thing we're going to look at, which is the commonest cause of spontaneous preterm birth, is acute choriamnionitis. Again, it's important to understand normal histology of the placental membranes to understand the staging of choriamnionitis. So you've got your amniotic lining, your amniotic mesoderm, your chorionic mesoderm, and then your chorionic leaf. So acute choriamnionitis is the presence of acute inflammation or neutrophils within the chorion, that would be here, amnion, or both of the extraplacental membranes or the chorionic plate. This can be with or without a fetal inflammatory response. I'm going to show slides of maternal and fetal inflammatory response. And to note, it's the fetal inflammatory response that's associated with longer term and more severe infection, risk of neonatal sepsis, and poor neonatal outcome. This picture then shows the sites of the maternal inflammatory response. That will be the chorionic plate and the extraplacental membranes, and the fetal inflammatory response will be here in the umbilical vessels and the chorionic plate vessels. The risk factors I don't think we need to go over. So pathophysiology as well. Acute choriamnionitis can be due to ascending cervical vaginal flora. That's the most commonest cause. Hematogenous spread or post-procedurally infecting organisms, but that's uncommon. So looking at the staging, stage 0 is a subchorionitis. So if you remember the diagram, a subchorionitis will be beneath the chorionic plate. That would be where you'd find the neutrophils. That would be a stage 0 maternal inflammatory response. Stage 1, which is early, is neutrophils here in the chorionic leaf of the extraplacental membranes. Stage 2 is neutrophils here within the amniotic or chorionic mesoderm. And grade 3 would then be association with necrosis of the amniotic epithelium. So that would be how it graded. You should see it on your reports. The grading refers to the severity of the acute inflammatory infiltrate, which can be mild to moderate or severe, and we base that based on the number of neutrophils that we see in the section. So that's how we grade it. So this would be an example of extraplacental membranes. You can see here you've got your acute inflammatory infiltrate involving the chorion, so that would be a stage 1. A stage 1 and grade 1. This again is a stage 1, but grade 2, because you can see there's much more neutrophils within the chorion here. Then here you can see these little cells here. These are the neutrophils. This is now in the mesoderm, so that becomes a stage 2. This would be a stage 2, grade 2, because there's much more of the neutrophils. And then the last slide, you've got necrosis of the amniotic epithelium, which would then be a stage 3. Then looking at the fetal inflammatory response, the fetal inflammatory response involves stage 1, the chorionic plate vessels or the umbilical vein, stage 2, the umbilical arteries, and stage 3, neutrophils in Wharton's jelly. Again, the grading is based on simply the amount of the neutrophils that we see. That's how we'll decide. So this is a stage 1 fetal inflammatory response. You've got an umbilical phlebitis. This is a muscular artery, and the inflammation involves the artery, which would then be a grade 2 fetal inflammatory response. Grade 3 is a necrotizing phonocytis, and Gamma showed the gross image of the candidal infection in the cord, and this is what we'll see. We'll see a microabscess at the periphery of the cord that you can see here, and this is a high magnification of that same abscess that he showed on gross morphology, and this is a Grocott stain that shows the fungal hyphae of Candida in what would be a candidal phonocytis. So looking at the recurrence rate of acute choriamnitis, it's 10 to 25%. Okay, so the next thing we'll look at, okay, we won't really look, okay, let's just look quickly at a chronic choriamnitis. Instead of neutrophils that we saw just now, what you get is maternal T cells, again involving the placental membrane. So these are not neutrophils, they are lymphocytes, maternal lymphocytes. This would be a choriamnitis, chronic, and this is a T lymphocyte marker. So you can see that they're actually T lymphocytes that are causing the inflammation, not neutrophils, as in the acute type. So let's look at placental pathology in low-risk pregnancies, just to break up the histology a bit. In a world with unlimited resources, we might send all placentas to pathology. However, routine placental examination is less situations where routine placental examinations is less likely to provide crucial information should be avoided. These include common genetic chromosomal malformation syndromes that are already well classified by antenatal testing, patients with previous adverse outcomes but no abnormalities in the present pregnancy, insufficient or absent prenatal care in a well newborn, and underlying medical disorders without acute exacerbations in the current pregnancy. There are few instances where a non-acutely ill mother without previous placental pathologies delivering a single-term near-term with normal birth weight, a 5-minute APGAR score of more than 7, and a normal-appearing fetus, a normal-appearing placenta, will benefit from histopathological placental examination. If placentas in these situations were no longer submitted to pathology, the overall rate of submission would substantially be reduced without clinical consequence. So no discussion of the benefits of placental pathology would be complete without considering the value of the placental pathology for the patient. Mothers and families naturally want to know why they have suffered an adverse pregnancy outcome. In the absence of a pathologic examination, the most honest answer by an obstetrician would be, "I'm not completely sure." And this is deeply unsatisfying for everyone involved. There are many potential benefits to be gained by engaging patients with placental pathology. The patients feel empowered when they know more about their pregnancies, past and present. They improve their general health literacy and knowledge. Their knowledge of their bodies is enhanced. They realize that others share the same problem, and they feel that they can be fully informed participants in future care decisions. Discussion of the placental pathology report can enhance respect for the obstetrician and the field as a whole. There's no feeling that information is being withheld. Recent studies have also addressed the importance of better placental pathology reports with patient-centered comments using lay language in the reports. Okay, so we covered acute choriamnitis. We touched a little bit on chronic. Remember, you get the maternal and fetal inflammatory response. The next thing, I'll cover abruption a little later if we get to it with the different types of abruptios. And the next thing that we will cover is maternal vascular malperfusion. So you can see maternal vascular malperfusion is a cause of spontaneous preterm birth, both early and late preterm. It's a cause of fetal growth restriction, as well as stillbirth and fetal death. So three gross findings elevate the likelihood of maternal vascular malperfusion. This is why, as Gamma alluded to, we have to have the gestational age on the history forms. So these are the gross findings. The decreased placental weight for gestational age, usually, as he said, less than the 10th centile, but almost always less than the 50th percentile. An increased fetal placental weight for gestational age because the placental weight is reduced to a greater degree than the fetal weight, and villus infarcts. The defining feature of maternal vascular malperfusion is accelerated villus maturation or distal villus hypoplasia. Accelerated villus maturation. What is this? I'll show you some pictures of it now. It's the defining feature of maternal vascular malperfusion. You have small, slender villi with reduced branching and increased syncytial knotting, and they resemble villi from a term placenta, which is why we need the gestational age, because you wouldn't know how to give it meaning unless you have the gestational age. Accelerated villus maturation also applies to term placentas, and it's a cardinal finding is that what you get is an alternating pattern of villus paucity and crowding. That's with the term placentas. So let's look at some pictures. This is a normal placenta, A and B, and here what we have is an increased number of what look like terminal villi. You can see they're much smaller. But on higher power, what you can see is that you have lots of syncytial knots, more than 30%, more than we're allowed to see, and fibrin agglutination as well. So this is an example of accelerated hypermaturation or accelerated villus maturation. This is a diagrams that demonstrate nicely the difference between what you expect to see in a normal, what you expect to see in a preterm birth. You can see you've got very big villi with this loose edematous stroma versus accelerated hypermaturation, where you've got villi that are small in cross-section, have decreased branching, lots of syncytial knots, and versus distal villus hypoplasia. Well, what you have here is that you have a paucity of terminal villi as compared to the stem villi. Remember the picture before, there were lots of terminal villi, but here you've got very few. They pencil it in shape, as the diagram demonstrates, again with increased syncytial knotting. So this is the spectrum that we're looking at for accelerated villus maturation for maternal vascular malperfusion as the main defining criterion. Villus infarction and infarction hematomas are also additional features of a greater severity maternal vascular malperfusion. Agama showed some infarcts, and this is what we'll see on histology. What you see here is that you've got villi that have lost their trophobasic blueness. If you compare, this is viable villi here at the end, and you can see the difference. So here they've lost their trophoblastic basophilia. There's collapse of the intervillus space. The villi are opposed to each other, and you can't see any detail within the villi. So this is what we'll see on histology when we sample these areas, showing villus infarcts. Infarction hematoma is a centrally hemorrhagic villus infarct. Maternal vascular malperfusion has a recurrence rate of 10 to 25%. So as Gama spoke about earlier, I just want to touch on this. Do placentas provide useful information in medical legal litigation? So I found some things that I think tie it up nicely. That the supposition that placental pathology in and of itself can help with a few claims of medical negligence related to adverse childhood neurological status is based either on anecdotal evidence or evidence that has not found its way into medical literature. Placental pathology findings are very rarely influential because for every pathologist making one claim, another pathologist will generally refute it. The latter statement, of course, applies equally to expert witnesses in obstetric, child neurology, neuroradiology, and neonatology. Okay, so what are we looking at next? Okay, Gama showed some images of massive perivillus fibrin deposition. So what we need histologically is at least 25% intraparenchymal or basal villi involvement. The etiology, there's 3 hypotheses, but it's not very well defined. Gama showed the exact same picture, actually. So this is an example of massive perivillus fibrin deposition that can also involve the fetal surface. The reason I showing that particularly is because it has a very high risk of recurrence, 30 to 60%. Okay, so then we've covered acute chorioamnionitis, maternal vascular malperfusion. We looked a little bit at massive perivillus fibrin deposition. We'll move on to velitis of uncertain etiology. Velitis of uncertain etiology can cause fetal growth restriction, late term and preterm, as well as being associated with central nervous system injury, which you can see here. Velitis of uncertain etiology is widely believed to represent a host-verse graft or maternal antifetal response that's caused by maternal T lymphocytes entering the villus stroma. A low-grade velitis of uncertain etiology is frequent and has limited clinical significance. If it's more extensive, if it's high-grade, it's associated with fetal growth restriction, stillbirth, fetal death, and CNS injury. So I'll show the difference between high and low-grade velitis of uncertain etiology. Low-grade velitis of uncertain etiology affects less than 10 contiguous villi, with at least 2 foci. High-grade, on the other hand, is more than 10 contiguous villi, and then it's divided into patchy or diffuse. But we'll just focus on that. It's the number of villi, low grade plus high grade, less than 10, more than 10. So this is an example of villi, and these little blue cells are lymphocytes. So this one shows a villitis of uncertain etiology involving less than 10 villi. And on immunohistochemistry, this is a stain for CD3 lymphocytes that show those cells within the villus parenchyma. So that would be a low-grade villitis of uncertain etiology. High grade, you can see that you've got lots of these villi, more than 10, that are involved by the same inflammatory infiltrate. Villitis of uncertain etiology has a recurrence rate of 25 to 50%. Just to touch on a chronic histiocytic enterocolitis, again, because of the recurrence risk, it's distinct from other idiopathic chronic inflammatory conditions. It's an uncommon lesion, and it's strongly associated with miscarriage, stillbirth, fetal death, fetal growth restriction, and preterm delivery. What you need to find is an infiltrate of maternal mononuclear cells, macrophages mostly, very few lymphocytes. So we've seen inflammatory disorders now that involve neutrophils, lymphocytes. This one is macrophages, 3 different types of inflammatory cells. And it's not in the villi, it's in the villus space. You need to have at least 5% intervillus space involvement, and at least 80% of the infiltrate should be CD8 positive. So this is an example of a chronic histiocytic intervillusitis, as opposed to the villitis that we just saw. You can see that these blue cells, the inflammatory cells, are in the intervillus space. And this is a CD68 stain, which highlights that these are histiocytes. Looking at the recurrence rate of a chronic villus intervillusitis, 75 to 90%, so a very high recurrence rate. Oh, so the next that we are looking at is fetal vascular malperfusion. A fetal vascular malperfusion is associated with fetal growth restriction, as you can see here, as well as central nervous system injury, and a stillbirth and fetal death. Gamal alluded to this as well. Fetal vascular malperfusion is most strongly associated with chronic or partial intermittent umbilical cord obstruction. It has less common associations, such as maternal diabetes, maternal antiphospholipid syndrome, antiplatelet antibodies, fetal cardiac anomalies, polycythemia, and thrombophilic mutations. All associations of fetal vascular malperfusion, which is different to maternal vascular malperfusion, involve Virchow's triad, which leads to thrombosis. The most common sequence is obstructed umbilical flow, which leads to increased intraplacental venous pressure and circulatory stasis within the placenta. What do we see in fetal vascular malperfusion? So I'll show you examples of, when we look at slides, what we look for is multiple foci, avascular villi, or villi with vascular stromal karyorrhexis. These are the defining features of fetal vascular malperfusion. So you can have small foci, 2 to 4 villi, that would be global fetal vascular malperfusion, or large foci, more than 15. That's segmental fetal vascular malperfusion. Global and segmental can be seen in the same placenta. So high-grade fetal vascular malperfusion is the total number of affected villi exceeding 15 per slide, or 2 or more fetal thrombi. So this is an example. You can see that I showed earlier the chorionic plate vessel within the placental chorionic plate, and this is a thrombus involving that, which would be in keeping with fetal vascular malperfusion. These are the stem villi, which you can see that the vessels are occluded by fibrous connective tissue, and these have then recanalized. So fetal and vascular malperfusion involves the vasculature within the chorionic plate, the stem villi, which then affect the rest of the villi within the placenta. These are examples of avascular villi. So you can see these villi here do not have any villi or any vessels within the parenchyma. They have stromal hyalinization, which is this dense pink material. And this is a larger focus of avascular villi, these pink villi that do not show any vessels within the stroma. To know, hypovascular villi, so villi with less vasculature, are not a recognized diagnostic feature of fetal vascular malformation. So antenatal findings associated with fetal vascular malperfusion. decreased fetal movement, category 3 fetal heart rate decelerations, prolonged meconium exposure, and neonatal complications are end organ thrombi, decreased platelets, and abnormal neurologic status. Fetal vascular malperfusion generally does not cause preterm birth or recurrent reproductive loss. So just to recap, fetal vascular malperfusion, the defining features are smaller intermediate-sized foci of avascular villi or villi with villus-stromal karyorrhexis. And the segmental pattern, you get large foci of avascular villi and villus-stromal karyorrhexis. Dama mentioned hydrops fetalis, and what we would see in the placenta here is enlarged villi with edematous stroma. See, these are different to the terminal villi that we saw initially, and they have increased number of fetal macrophages or Hoffbauer cells. So these cases are generally divided into immune and non-immune causes of the hydrops. We just touched on abruptio. Do we have time? We have like 5 minutes. So since abruptio is something that we commonly see, what happens here is that you get loss of maternal vascular integrity. And what happens is you get accumulation of maternal blood between the fetal surface of the placenta here and the uterine wall after 20 weeks. The 3 main categories are classic acute abruption, acute marginal abruption, that's here where you get abruption at the edges of the placenta, and a chronic abruption. What we see is intravillous hemorrhage, hematoma with underlying infarction, and chorioamniotic hemosidrosis that's in the chronic type. So Kamat actually did show these pictures as well. So this is an acute abruption where you have the retroplacental blood clot that's indenting the parenchyma, circumvallate placenta that's associated with chronic abruption. And then microscopically, what we see, I showed the infarction earlier, these huge areas of degenerate villi that lose their basophilia, lose the intervillous space, and don't show any detail. And then in the adjacent parenchyma, you'll see this intravillous hemorrhage, which is characteristic of an abruption. A chronic abruption, you see this brown pigment is hemosiderin deposition, and you get this accumulation of hemosiderin-laden macrophages in the free membranes or the chorionic plate. That's what we would find in a chronic abruption. Yeah, so continuing evaluation of placental pathology is crucial for clinical practice and research in obstetrics and neonatology. We do need a better understanding of placental development across gestation and of the underlying etiology of adverse pregnancy outcomes. The placenta has many secrets yet to be revealed, and placental pathology is the venue to understand relationships between structure, function, and pregnancy outcomes. These goals depend on a culture that believes in the relevance of appropriately submitting placentas for pathologic evaluation. Thank you.
Thank you to our 2 presenters. Very comprehensive, but very succinct to the point in terms of covering the topics. Can we take some questions on the 2 presentations? Maybe I can just ask an officer.
Thank you very much, Mr. Adeli. I'm Bruce Talks. My name is Leon Moran. I think in the first talk, I came slightly late, but you're in the middle of giving a very long list of possible indications for placental histology. It was very long. I was trying to work out what sort of proportion of all deliveries that would be. It might be quite a large proportion. So let's say in UKZN we have 200,000 deliveries per year. Given that is the case, and these are done in quite a large number of facilities across the province, what kind of capacity is there to actually examine the centre in terms of numbers? Because if everyone starts sending the placenta for all those indications, you might have tens of thousands of cases, would the department be able to handle that in terms of just the total load? And I'm not sure if all the pathologists are all equally competent in specific placental pathology, or it's a more special sort of subspecialist field? That would be my first question, because if we're going to make guidelines about when the placenta should be submitted, then we have to know that there'll be capacity to deal with the numbers that will be sent according to those guidelines.
Yes. So, the hope with these guidelines is actually to reduce the submission rate rather than to increase it. Because currently those placentas that we get don't have any history. We don't know why. We don't have any history from, say, about 90% of the placenta we get. What I was saying was that the hope would be to decrease the number of placentas that are submitted if we use the guidelines. Because currently we get placentas that are submitted without clinical indications. So the aim of this is to actually decrease the placental submission rather than increase it with a left gamma platter.
I think the reality is the placentas are only being sent for a very small portion of the facility. Now, maybe in those specific facilities, they are either oversending or they're just failing to write the indication. There might well be indicated cases. It's just that the person who's sending it is neglecting to write the details that you need. Because I don't think the placenta is being sent from all cases, even in those facilities that are sending. But I think the great majority of all the hospitals, let's say, are not sending any placentas for histology. So I think I'm just saying that if we put out guidelines and we try to enforce those guidelines from, let's say, district hospitals, there might be a much larger number.
Okay, now I hear you. Yeah, I think in terms of numbers, look, there is a problem with capacity with histopathologic assessment in general. But looking at placenta, and I've discussed why we are where we are, no, we do not have perinatal pathologists. Okay, that's the short answer. But we are following the new Amsterdam criteria, and it is making a difference with the way we're putting our reports. They're much more succinct, and they are directed to help patient and fetal management. So I think that if you do put in the criteria and it is structured and enforced, I think it will help the placental pathology in general. It would also help the pathologist, if the history is succinct, to able to put those placentas to more targeted and quicker. So I think that we do have the capacity to see the placentas. Also, some of the private laboratories also assist with the state work as well. So we do have a robust system with histopathologic assessment. I'm sure that with your other biopsies as well. I don't think you're taking too long to get those results out. So placenta is similar, and if we could just get those guidelines done properly for when it should be submitted and provide the information, it would be much quicker for us and much more useful for you as well. I think capacity is there. Capacity is there.
Thanks. Thank you for the question. I think I will first just address the issue of the guidelines I presented and the list. I concur with you that the list is quite long, it's extensive, and I'd also say that if we were to follow those guidelines, there is a possibility that we can actually have lots of placentas, which I think at one point during the presentation, I did suggest that in platforms like this, we can actually have a discussion to say, based on our capacity, based on the number of deliveries, with these international guidelines, how can we modify them for our own environments? For example, I'd add that in Eastern Cape, for example, when I was with Prof. Wright, she indicated that in their area, the cases that they submit, it's cases of what looks like severe chorioamnitis, they submit those. Intrauterine fetal demise, all of those ones, they get submitted. The other cases they submit would be if there is a severe hypoxia, like hypoxic encephalopathy. I think she mentioned those three to actually cut down the numbers, but she still gets quite a big number of cases, even though she's there is that restriction in terms of what they are submitting. So I think I would agree with your assessment that those guidelines, they are extensive, that lead to too many cases, and then without the full capacity. Because like my colleague said, we don't have perinatal pathologists in the country. Actually, sorry, I'm wrong. We do have, but they are very few. The ones I'm aware of is Prof. Colin Wright. She's retired, still working. I think it's Prof. Kumala Pillay. She's based in Cape Town. Probably the only one there in Cape Town. Schubert. So like I can count, there are very, very few. And then other people, they have an interest in placental pathology, including myself, probably Ashmini as well. So then one would actually do courses in this area. Like personally, I have recently completed a placental pathology course with US Canada Academy of Pathology in the last couple of months. So and then the rest of the pathologists, they do placental pathology as part of the general pathology. They may not necessarily have had, or unless they've gone through some course, but not many courses are happening either on placenta in the country. So for general pathology, pathologists, there may be challenges in terms of reporting. I think one of the things that I've picked up, especially when we don't get clinical history, with regard to fetal vascular malperfusion, the changes of intrauterine fetal demise and fetal vascular malperfusion, there's a big overlap. So sometimes you look at it, like you might find a report comes back, is it a fetal vascular malperfusion? Is it placental involution? And then we need a correlation with the clinical history in terms of what exactly transpired. But all in all, I think we need platforms like this to say, for our region, our area, this is what we will be submitting. And then if you know that you have a high percentage of intrauterine fetal demise, you may say that we're only going to start with intrauterine fetal demise cases and maybe severe hypoxia cases. That's what we're going to be submitting. And then in that way, the number of cases will be limited. If Dr. Msimang says we have our capacity is sufficient, we can see more, then we can actually say, what is your next step in terms of what you want next to be examined? Then you submit that. But to submit everyone with gestational hypertension or diabetes may not necessarily be feasible. I think at this moment, we look at some of the NHS placentas, like at the moment, we are seeing cases from maybe February, April this year. So you can see the log. And then one mentioned that in Free State, for example, they've got placenta that are sitting somewhere for the past 12 months or so, not being examined. So the capacity issue is there. And of course, we're also aware that currently DOH and every other state's entity is having funding issues. So it's also not cheap. Although it is cheaper if we were to compare that, if it will be useful in your litigation cases, I'm sure it's be cheaper to pay 3,000 rand to have a placenta assessed and go and pay 20 million rand to the lawyers because of the adverse pregnancy outcomes. So it's always a balancing act. Thank you. Maybe I have gone overboard in my answer.
Yeah. No, thanks. I think it was a very well answered by both presenters, and it's certainly a question that has been posed previously. But I think there's only one center in the country that has formalized criteria or guidelines for that. It's Tygerberg, and I think maybe it's something that we need to look at UKZN just to formalize the process, because so far we do have a placental requisition form in place. It's not widely used, but it's something that we can certainly make available to all the centers, especially the training centers. There is a placenta requisition form. And I think if possible, maybe we could make more orders and distribute it much more widely. That will enable us to actually ensure that the clinical history component is covered. But I think maybe from both departments, we could maybe look at see how we can formalize those guidelines, because they are very important. And yeah, I think as I totally concur with what they were saying. Yeah, thanks. And then we just have one question online. What nomogram would you suggest for placental weight assessment? I'm not sure. We've got the standard charts, and especially that we use for autopsy pathology. I'll just need to get that reference. I just don't have it offhand right now. But we sometimes get autopsies for maternal deaths and all that. So we need to assess the fetus with the placenta and mom. So we've got nomograms and charts that we use as references that we can. I just don't have the reference offhand, but we do certainly have it, and I can share that with you. Awesome.
Thanks for the interesting talk. Just regarding I have spoken to colleagues at Tigerbird, and they've said with their placental pathology, they've actually found it far more helpful than actually like doing the blood gas for the HIEs and neonatal encephalopathies and that. So I do think it has a place, and I think we need to maybe get more capacity. But I think in terms of the litigation, the HIE, they've got very cut down. For example, if you have a clinical abruption, don't send. If you've got an antenatally diagnosed cause for their IUD, don't send. There are things you can cut down quite a bit. If the baby is born normal, low APGAR, low risk, don't send. It may not cover everything, but it does trim. So it's, I think, about 8 or 9 indications that they have, that they trimmed quite a bit, and it seems to work quite well for them. The one thing I noticed, maybe I missed it, is, I mentioned before in our discussions, TB. Because we've been asked, and the kids keep asking us to send the placenta and have you made sure that there's no congenital TB. And the only way they say for us to confirm is if it's in the placenta. So part of the protocol for TB, even when I look to the guidelines, even in Cape Town, active current TB and TB treatment must be central. And it is one of the areas that we said does need treating. And I think the most important thing for the histopathology at the moment is your maternal vascular malformation, because that's got the high risk of recurrence, and we can do something antenatally for the next pregnancy. Say she's high risk, possible aspirin and heparin to address that. And then the TB is to address management of the baby, because if there's no clinical symptoms, but you have placental pathology, that does potentially change the pediatric management of the baby. So it's just those kind of things. I think, like you said, we do need to sit down and formalize our protocols and get it done.
Yeah, no, thanks, Nai. I think we've gone a bit over time.
Yeah.
So,
Thank you.
Sorry, one more question. Sorry.
Yeah, thanks. I just want to comment firstly on the maternal vascular malperfusion. And that's often brought up in the context of litigation, or when there's litigation because a child has ended up with cerebral palsy. And the claim is that this is due to hypoxia during labor. And they're saying that that was mismanaged. Now, if you then had a placental histology which shows maternal vascular malperfusion, I think that can explain why that fetus was vulnerable to hypoxic stress in labor. But I don't think it really affects the litigation, whether you can defend that or not, because that depends on whether you monitored the fetus in labor and whether you intervened if there was a problem. So whether there was maternal vascular malperfusion or not, if you didn't monitor the baby and you didn't intervene if there was a problem, then you're still liable. So it sort of explains why this particular baby seemed to be vulnerable to the hypoxia, but it doesn't necessarily help you to defend yourself. If you properly monitored and you properly managed, but the outcome still happened, then you can defend yourself. But so I think really where it might come in is if you've got an alternative explanation from the placenta, like there was chorioamnionitis, and whether or not you intervened, then the baby would still have been affected. So I think that one is quite a sort of subtle field which hasn't been maybe that carefully sort of explored yet as to how exactly in the court the placental histology will be able to help. But the one thing that I was really interested in the talk about the fetal vascular malperfusion was this issue of the hypercoiled cord, because that's not something that we concentrate much on from our side. I mean, that's not really something you send to the lab. You could maybe look at it when the baby's born. And I don't think people comment on the extent to which the cord is coiled as an explanation for maybe a poor outcome. I'm not quite sure what's the definition of a hypercoiled cord. To what extent must it be coiled for you to say that's abnormal and might actually cause malperfusion? I saw the one picture where it was associated with constriction, which was, I'm not sure whether the constriction then caused the coiling or whether the coiling caused the constriction. I'm not quite sure. And then my last question was where there was the cord divided into two before insertion. Where are the vessels? There's one artery going one part and one in the other, and what about the vein? How does it work? Thanks.
I think with the coiling, there are definitions that are there. So for hypercoiling, is defined as having more than 10 coils per 10 centimeters. And then a hypocoiling, that is a less than one coil per 10 centimeters. On their own, they have been found to be associated with morbidity and mortality. And then both hypocoiling and hypercoiling, they are also included in the so-called obstructive lesions of the umbilical cord. I may not necessarily at this moment be able to fully explain the obstructive nature of it. But with hypercoiling, for example, then there are different kinds of hypercoiling. So they're like segmental type, there are target types. So those ones often they also have more morbidity relative to the other two types, which I'm just not recalling the name at the moment of the other. So in total there are like 4 types. So the two types, target type as well as segmental type, they tend to have a deep indentation or deep constrictions within the actual cord. So which then they cause obstruction in those areas. So then what then happens that in those particular cases, you may actually find features of fetal vascular malperfusion. And then when you see that, like hypercoiling, hypocoiling, then what you report is if it's just that in isolation, when we say umbilical cord at risk, I mean that it's at risk for fetal vascular malperfusion. And then most of those cases, one will look more thorough for the features of fetal vascular malperfusion. If you don't find them, want to put through more tissue and see if you can actually find the evidence to suggest that. Because with the fetal vascular malperfusion as well, it has been found to also be associated with things like cerebral palsy or neurodevelopmental disorders in the baby. So it becomes an important finding, you know. I think you had another question earlier.
How it divides, the cord divides.
Yeah.
Into.
Yeah. So with the cord dividing prior to the insertion into it essentially it means that cord is not protected. Then the Watson jelly has not developed all the way down. Then in terms of like, is it the artery or vein going in the other direction? That would be difficult to say when you have not looked at the actual sections. But in general, what we'll do, we'll cut those sections and look at them. But we don't necessarily usually try and answer that question, say whether the cord is the artery is going to the left or to the right. We describe that finding. And then what would be important for us to know is that are there 2 arteries and 1 vein? Because when we see 1 artery, 1 vein, then that is generally on its own means that that baby needs to be investigated because there may be some congenital heart abnormality that that baby may have and other disorders. So when we report that there's a single umbilical artery, for example, then it is appropriate to have the baby just screened for possibilities of congenital heart disease. If it is there, if there is nothing, then that's great, you know. But if it's not screened, then a couple of years later, it comes up, then it's like we do not do the necessary due diligence. I'll go back to the question you had about maternal vascular malperfusion and the CP. I think when it comes to the CP diagnosis and the litigation, the real issue often it's more about the events in the intrapartum stage. So maternal vascular malperfusion is not just an event that happens in the intrapartum stage. It's an event that tends to be chronic. So in that context, I would forward that one may come and say that, yes, this baby has been having some issues in terms of its growth, probably going on prior to the intrapartum stage, and then to then put everything that the CP that has developed here is just because of the intrapartum stage, while we have the other finding, then you put that as an alternative explanation, unless the person can provide the evidence that supports that indeed you did not monitor the baby. Because remember that in these particular cases, you also, in your defense, want to present an alternative and create some elements of doubts that can explain what has transpired. So if there is no other explanation in the intrapartum that supports the theory that no, the sentinel event was intrapartum, then I would think that the court will have to accept that the explanation that you are finding this maternal vascular malperfusion should explain. And then as I remember, even Dr. Matari did mention that you can get neurodevelopmental disorders due to the maternal vascular malperfusion as well. So in that context, I think you can present that particular evidence, and then the claimant will have to provide the evidence that supports that you did not actually monitor the baby appropriately at the intrapartum stage. Thank you.
Thank you.
Thanks, colleagues. Thanks. There's just a request to share the presentation. But thanks to the presenters and thank you, everyone.
Thank you. Yeah.
Recording stopped.